Hey
Okay.
everyone, thank you so much for joining us today. Sorry for the little delay, but we'll go ahead and get started. And again, thank you for being here to listen to our echo session on dementia in detail, focusing on vascular dementia. Again, we're going to go into our introductions and announcements, moving into our didactic, followed by our closing and reminders. Everybody's been muted upon entry, so if you have any questions along the way, feel free to unmute yourself and introduce yourself and ask your question. We are CME accredited, and this session is 1 hour and approved for 1 AMA PRA Category 1 credit. We are grant funded by the Health Resources and Services Administration, and this information or content and conclusions are those of the author and should not be construed as the official position or policy of HRSA, HHS, or the U.S. government. So we'll go ahead and move on into our introductions. We have about 50 on the line. Thanks again for being here today. If you can go ahead and include your name, your role, your site, and your location in the chat, it would really help us. We also really like to see where you all are joining us from. And then if you do want CME credits, it's always nice to have you guys sign in so we can make sure that you are accounted for. While you do that, we'll go ahead and have our hub team introduce themselves. I'll get started. My name is Nika Safil. I'm the GWEP project manager here at UC Irvine in Orange, California. And then I'll go ahead and have Dr. Pereira introduce herself.
Hi, everyone. I'm Manisha Pereira. I'm one of the geriatricians here at UCI. I practice in Orange at the Senior Health Center. Welcome.
Thank you, Dr. Pereira, and PA Valerie George.
Hi, everyone. My name is Valerie George, and I'm a PA, and I work at the Senior Health Center with all three of these doctors, Dr. Diaz-Ambuja, Dr. Pereira, and Dr. Sagal. So glad that you could join us today, and welcome.
Thank you, Val, and Dr. Sagal.
Hi, everybody. Welcome. I'm Sonia Sagal. I'm a clinical professor in the Department of Medicine and the Division of Geriatrics and Gerontology here at UCI. And I just want to welcome you.
Thank you. Thank you. And thank you all for being here. We see people from Virginia joining us. Let's see, from Michigan, UCI, Nevada. Again, thank you all for being here and for letting us know who's on. I will go ahead and introduce Dr. Catherine Diaz-Ambuja is here. She works at our Senior Health Center and at our FQHC here in Orange County, and she's going to be presenting today on vascular dementia. And Dr. Diaz-Ambuja, I'm going to stop sharing so you can share your slides.
All right, thank you so much. Let me just get my slides on the screen. Can you see the full slides or the notes?
We can see the full slides.
The full slide, great. All right. Good afternoon, everyone. My name is Dr. Catherine Diaz-Ambuja. I'm one of the geriatricians and family practitioners. I work at the UCI Senior Health Center in Orange, and I also practice family medicine and geriatric medicine at the Family Health Center in Santa Ana with UCI. So today I will be presenting on the topic of vascular dementia. So the agenda for today, I'll go over a case presentation on a patient I saw a few years ago. I'll go over an overview of what dementia is, a history of vascular dementia, how to go about with diagnosing vascular dementia, what are the differences between vascular dementia versus Alzheimer's dementia, what risk factors are there for developing vascular dementia, and what treatment and what the prognosis is for someone who is diagnosed with vascular dementia. So this case presentation, this is actually a patient I saw when I was a geriatric fellow here at UCI in the geriatric clinic at the Family Health Center in Santa Ana. So this patient is a 68-year-old male with a past medical history of type 2 diabetes, chronic kidney disease, peripheral artery disease. He had 2 strokes in the past, one in 2014, one in 2018. So by the time we saw this patient, it was 2020. He had residual left-sided weakness, CAD, hypertension, hyperlipidemia, hypothyroidism, and normocytic anemia here for a memory evaluation with our geriatric clinic in Santa Ana. So he describes his experience as having memory difficulties that started at the time of his first stroke in 2014. Before his stroke, there were no memory issues, he recalls. He said he was sharp like a GPS. In the last 6 years, he's noticed that it's hard for him to recall things, so more short-term memory issues. So for example, he says he often asks his wife for the same questions repeatedly, or he'll have to repeat conversations. He will forget what she tells him in a matter of minutes. And the wife, who was also there with him, said that he rarely registers what she tells him and often forgets where he places things. So a lot of misplacement of objects around the house. The wife also reports he's having what she calls temper tantrums, where they occur once a month. She describes these incidents as moments when the patient gets really frustrated with himself because of his difficulty with his memory. He will get very upset with himself and those around him, leading to arguments. But then within minutes of having one of these tantrums, he'll forget it ever happened. He also reports forgetting if he's even eaten a meal that day. So he'll sometimes eat more than 3 meals a day because he forgot he had breakfast, lunch, or dinner. He has trouble remembering if he took his medications that day, and often the wife would have to help him with managing his medications and checking his pill box to make sure he took his medications that day. In terms of social history, he lived at home with his wife and his 10-year-old grandson. He's not been driving since his first stroke in 2014. In terms of ambulation, he uses a walker to walk around the neighborhood. He has not gotten lost around the neighborhood, according to his wife, but there are times when the patient says that he feels like he might forget what direction to go to which direction to take. He requires some minimal assistance with some of the activities of daily living and a few of the instrumental activities of daily living. And his level of education, he went up to the 6th grade. In terms of his other history, surgical history, he had a toe amputation in 2020. Substance use history, he was a former smoker. He smoked for 2 years, 1 cigarette a day, so not very heavy with smoking history. No alcohol use present or in the past, no other drug use. Family history is pertinent for diabetes in both brother and sister. And for medications, here in front of you, he's on aspirin and atorvastatin, benazepril. So he's on the right medications for his history of hypertension, stroke, diabetes. He's on sertraline for depression, which has been pretty well controlled. And he's on a thiamine and multivitamin tablet. So when we saw him in the memory clinic, because of his limited level of education, we thought it'd be more appropriate to do the cognitive ability screening instrument short version. So it's called the CASI for short. The CASI provides the quantitative assessment on attention, concentration, orientation, short-term memory, long-term memory, language, visual construction, list generating fluency, abstraction, and judgment. And studies have actually shown that the CASI is used across different countries and shown cross-cultural applicability in screening for cognitive impairment. So that's why we chose this instrument versus like the MMSE or the MOCA. So, and the way you can interpret the score is based on the years of education. So in his case, he had 6 years of education. So in order to score abnormally, you would have to get less than 23 points. So when we went through the cognitive testing, he scored a total of 17. So he did score abnormally for his level of education. So he did have trouble with the delayed recall. So we gave him 3 words to remember. And at the end, when we asked him if he can remember those 3 words, he had trouble with any cues. So category cues or multiple choice cues, he was unable to recall the words at all. So he got no points there. So he lost a lot of points with that part of the exam. Then in terms of functional evaluation, trying to look into, is this person are we thinking about dementia? So we have to assess their functional status. So he's pretty independent with most of his ADLs, which are the activities of daily living. He's able to bathe by himself, dress himself, feed himself, groom. He has no issues with incontinence or toileting or transferring. With his instrumental activities of daily living, he's independent with using the telephone and performing housework and things around the home, doing laundry, meal preparation. But he needs help with certain more complex tasks like shopping and taking medications. And he can't handle his finances anymore. His wife has taken over this role. And he no longer drive after his stroke in 2014. Then on physical exam, his vitals were all pretty much within normal limits. Blood pressure maybe was a tiny bit elevated, but not too bad. His cardiovascular exam was normal. His mental status exam was appropriate. He was oriented to person, place, but not time. He had pretty normal language output. We did a neurological exam. Cranial nerves were intact. The only thing we did notice was he had a facial droop mildly on the left side. He had a normal strength in the on the right side, upper and lower extremities. On the left side, he had some weakness on the left upper and lower extremities. He also had some trouble with coordination. So in terms of rapid alternating movements, he was a little bit slow, mostly on the left side as well. So this kind of coincides with his subjective mentioning of residual left-sided weakness after the stroke he had suffered. And then we went over some laboratory tests that he had done. A lot of these are labeled as abnormal, but they're stable for him. So he does have history of CKD. So his creatinine was 1.6, his GFR was 43. That is actually his baseline. His liver panel, for the most part, was pretty normal. He did have a bit of low albumin, but it wasn't significantly changed from his baseline. His CBC did show a normocytic anemia, which coincides with his baseline. So there weren't anything that was abnormal for him. And then he did have an MRI done. This MRI was done after his second stroke in 2018. So in the MRI results, it showed it demonstrated the old stroke that happened in 2014, which showed up as encephalomalacia of the right parietal occipital lobe and the left occipital lobe. So this is the prior one from 2014, and then it showed the new infarct in 2018, which was a punctate focus of diffusion restriction, the left aspect of the medulla. So this was the acute infarction. So these were the MRI results showing that he's definitely had strokes in the past, and at least at the time the MRI was done, an acute stroke. So in our assessment, we diagnosed him with vascular dementia in the setting of a history of ischemic stroke resulting in left-sided residual weakness. He was having mild memory deficits after the stroke. So it was that kind of coincided with that stepwise pattern. So after the 2014 stroke, he's had this persistent issue with his cognition, and he scored abnormally objectively on our CASI score. In terms of his functional assessment, he was mostly independent with his activities of daily living, but he needs assistance with his instrumental activities of daily living, which is an acquired functional deficit. So with that, we were confident that it was most likely related to vascular dementia. So our plan was to optimize his cardiovascular health. So we wanted to be on the right medications to keep his blood pressure under control, to keep his hyperlipidemia under control and his diabetes under control. So we said to continue that, make sure he has good follow-up with his cardiologist and his primary care caregiver, because he had mentioned that sometimes he when he's out walking or he's out ambulating, he feels like he might lose his train of where he's going, his orientation. We asked him to purchase a tracker bracelet to have a way of tracking where he is in case he does go out alone, although we did recommend that he go out with someone and not by himself. We also wanted to talk about any sensory deficits. So if he's having hearing or vision loss, he didn't have any hearing issues, but in terms of vision, we'd ask him to make sure he's up to date with his glasses or his prescription glasses for vision correction. And we talked about advanced care directives. So anytime we diagnose anyone with dementia, especially those who still have ability to make decisions, we want to make sure they have advanced care directive in place. So we had that conversation to make sure the family starts talking about that, and the patient can be an active participant in his advanced care directive. And the wife had mentioned that she was a little bit stressed out with providing care for her husband and was wondering about respite care. So we provided some resources on respite care for her and for the family. So that was our plan. So with that, I'm going to go ahead and go over the overview of dementia, and then we'll go talk about vascular dementia. So as a reminder, dementia refers to several disorders that can cause significant decline in at least one or more areas of cognitive functioning, that results in also in acquired functional deficit or decline. And it's not an inherent part of aging, so it's not a normal process of aging, and it's different from normal cognitive lapses. Dementia is also known as major neurocognitive disorder, is an umbrella term that encompasses different etiologies. The Alzheimer's dementia, which we're all very familiar with, is the most common form of dementia, which accounts about 60 to 80% of cases. The second most common is vascular dementia, which accounts for about 15 to 20% of cases, and it's followed by other etiologies that are less common, but still things to look out for. Lewy body dementia frontotemporal, other types like Huntington's. There's HIV-related dementia. There's, of course, normal pressure hydrocephalus, so the other less common forms, but things that we always have on a differential. And in the asterisks here, there's mixed dementia, which is relatively common, especially in those who have Alzheimer's and vascular dementia, because a lot of patients have vascular risk factors that can cause vascular insult to the brain. So remember there are mixed dementias as well. So a little bit of history about vascular dementia. Starting in the 17th century, the picture down below is the picture of Thomas Willis. Thomas Willis was the English physician who discovered the circle of Willis that we're all familiar with when he was researching the anatomy of the brain. In 1672, he described a term called post-apoplexy dementia, which was referring to dementia after an episode of incapacity or speechlessness. So he was already depicting an episode of stroke and then noticing that there was a change after that person had a stroke. So this was depicting vascular dementia in the late 17th century. He also depicted, quote, dullness of mind and forgetfulness, and then afterwards a stupidity and foolishness, end quote, contained several of the hallmark features of the entity known as vascular dementia. By the end of the century, physicians concluded that post-stroke vascular dementia was more likely associated with less fatal ischemic stroke. So they started seeing a correlation between ischemic strokes and development of cognitive issues in dementia. In the 18th century, arteriosclerotic brain atrophy was attributed to lacunar stroke. So when they started doing autopsies on brains, they started noticing a correlation, and they found inflammatory infiltrates and vascular lesions. Then in the 20th century, the influential German psychiatrist Emil Kraepelin proposed a term, and excuse my German, das arteriosklerotische Irresen, or also known as atherosclerotic dementia, which is a form of senile dementia. So he was already describing vascular dementia. In 1974, another research team coined the term multi-infarct dementia, which is a form of vascular dementia we'll go over that's due to multiple strokes. And then in 1991, the National Institutes of Health organized the International Workshop on Vascular Dementia that resulted in the consensus on how to diagnose vascular dementia. So that was in 1991. So again, vascular dementia refers to a decline in thinking skills caused by conditions that block or reduce blood flow to regions of the brain, depriving them of oxygen and nutrients. So some basics about vascular dementia. Dementia can develop in about 15 to 30% of stroke patients within 3 months after stroke. And about 20-25% of stroke patients can develop delayed onset of dementia. The following risk factors increase someone's risk of developing dementia after a stroke. So if they're older, if they have a lower level of education, a lower income, smoking history, lower blood pressure or orthostatic hypotension, if they had larger or recurrent strokes and large white matter lesions. So if we think back about the case presentation, my patient had a lot of these risk factors that would also contribute to him having dementia after a stroke. So he was older, he had a lower level of education, he did have some smoking history, and he had recurrent strokes too. So he already has a lot of those risk factors. And the impact of vascular conditions on thinking and skills varies widely. It all depends on the severity of the blood vessel damage, if it's a large vessel or small vessel, and the part the brain affects. A lot of times with vascular dementia, there's more characteristic executive functioning issues versus memory. So that's something that differentiates vascular dementia versus the other dementia. So there's a lot more executive functioning issues that affect someone's ability to perform instrumental activity of daily living. So again, memory loss may or may not be a significant symptom. In the case of the patient I presented, it was a significant symptom, but again, it all depends on where in the brain the vascular insult happens and where there's lack of blood flow. So in terms of diagnosing vascular dementia, there are core elements that you need to have. You have to have an acquired cognitive impairment, vascular damage that's seen on imaging, a temporal link between the two. So if someone had a presenting with cognitive impairment, there has to be some sort of preceding vascular damage that you can see on imaging, CT or MRI. And you have to also exclude other reasons for dementia, of course. So this graph here shows the stepwise pattern with vascular dementia. When it's purely vascular dementia, patients will present with an acute change in their cognitive function, and usually will stay as it is unless there's a continued insult to the brain. Of course, if it's a mixed etiology with vascular in Alzheimer's, then they could have more progression because of the Alzheimer's etiology. But if it's purely vascular, it would have a stepwise pattern that coincides with the vascular insult that they had. And again, depending on what part of the brain there was that the stroke happened or the lack of blood flow, people have different kinds of motor symptoms. So they might have aphasia, they might have apraxia, they might have tremor or difficulty with balance. It might be unilateral, it might be upper or lower extremity or both. So it all depends on what part of the brain, what territory has been affected by the loss of blood flow and nutrients. So the different types of vascular dementia, we categorize it based on hemorrhagic versus ischemic, of course. Most of the time with hemorrhagic strokes, it's due to hypertension, a cerebral amyloid angiopathy. Of course, if it's a major bleed due to trauma, it could be subarachnoid or subdural, maybe weakness of the blood of the venous system in the brain can cause subdurals as well, or subarachnoid. There's also ischemic, so either large vessel or small vessel. With large vessel disease, they're further divided into post-stroke dementia versus multi-infarct dementia. And then with small vessel disease, you can think of single lacunar strokes or subcortical ischemic strokes. So the common form is subcortical ischemic vascular dementia caused by small vessel occlusions with multiple lacunar infarcts by hypoperfusive lesions resulting from stenosis of the arterioles. In the large vessel subtype, post-stroke dementia is the most common form of acute onset vascular dementia. The term multi-infarct dementia is used when the dementia develops after multiple large vessel thrombotic or embolic strokes. And another form of acute onset is the post-stroke dementia, which includes the strategic stroke caused by single strategically located stroke affecting a large vessel arterial territory. Most often, the small vessel disease, like the subcortical ischemic strokes, can have more of a slow clinical presentation, and it can be over time. So what differentiates Alzheimer's versus vascular dementia? In vascular dementia, cognitive symptoms, like we said, depend on the anatomy of the ischemia. So if it's large vessel, if it's small vessel, if it's several vessels that are compromised, and where in the brain the insult happened, there's more executive function dysfunction that's commonly seen in vascular dementia. The cognitive changes vary depending again on the anatomy of the insult that happened. Patients are more frail than those who have Alzheimer's dementia, and that's really due to their comorbid condition. So someone has vascular dementia, they already have a lot of cardiovascular risk factors that in itself make them very frail. They have a lot of other complications. A lot of times they have coexisting comorbidities like kidney problems, hypertension, heart failure, diabetes. So they're usually a lot more frail than those who just have Alzheimer's dementia. And because of that, their mortality is higher. They've also found that in those who have vascular dementia, there's more likelihood of depression and apathy versus those who have Alzheimer's dementia. In this table, it sort of summarizes the difference between vascular and Alzheimer's. This is taken from the reference here I listed for you from a 2003 paper, which I thought was a nice summary of the difference between vascular and Alzheimer's. So again, with vascular, it's sudden. It can be gradual depending on, again, the location of the vascular insult. If it's more of ischemic, small vessel disease, it can be more gradual and less prominent, but onset tends to be a little bit more sudden. Versus Alzheimer's more gradual. Progression is that slow stepwise fluctuation depending on the vascular insult, versus Alzheimer's more constant insidious decline. There's more likely to have neurological deficits because of where the stroke happened, whereas in Alzheimer's, there's really not, you shouldn't really be seeing focal neurological deficits. In terms of memory and vascular dementia, it's mildly affected most of the time, whereas in Alzheimer's, it's more affected early and there's more severe deficits with memory. In terms of executive functioning, it's in vascular dementia, it's early and severe, whereas in Alzheimer's, it happens later. And in terms of dementia type, there's a lot more common subcortical vascular dementia versus cortical in the Alzheimer's disease, where the amyloid plaques are affecting the brain. In neuroimaging, you'll see more infarcts or white matter lesions, where in Alzheimer's, you'll see hippocampal atrophy. And in terms of gait, the patients who have vascular dementia often have more disturbances earlier on versus in Alzheimer's. It's usually normal unless it starts progressing and then the person starts developing more gait or mobility issues later on in the Alzheimer's disease process. And in terms of cardiovascular history, with vascular dementia, there's more history of strokes, of course, in the past, vascular risk factors, transient ischemic accidents, whereas in Alzheimer's disease is less common. And this is just comparing a purely vascular dementia person versus a purely Alzheimer's dementia person. So again, people can have a mixed etiology where they can have Alzheimer's and have vascular. So this is just comparing if someone were to have pure vascular versus purely Alzheimer's. So in terms of the pathophysiology, aside from what we talked about having a vascular insult to the brain, they've also found that there can be cholinesterase inhibition in those who have vascular dementia. So there are studies that show that vascular dementia also has cholinesterase deficits that are independent of Alzheimer's dementia and so these patients who have vascular dementia can also benefit from acetylcholinesterase inhibitors. So that's something that they found. Also, in terms of risk factors, we've kind of talked about the cardiovascular risk factors for those who have vascular dementia. So things like hypertension, hyperlipidemia, diabetes, cardiovascular disease, sleep apnea, stress, depression, having more a sedentary lifestyle, poor diet, smoking, atrial fibrillation. So these are all what we call modifiable risk factors that we have relative control over, or we have treatments that we can really help modify these risk factors, whereas the non-modifiable risk factors are things that are beyond our control. So someone's age, genetic factors, ethnicity, family history, and prior history of cerebrovascular disease that we can have no control over. So in terms of other non-modifiable risk factors to think about, in addition to those that I listed, hypertension, atherosclerosis, diabetes, and other cardiovascular risk factors, it's important to also think about autoimmune vasculitis. So people who have lupus or granulomatosis, angiitis, they have more likelihood of having vulnerable vessels that can cause stroke. In terms of infectious etiologies, so infectious vasculitis, so neurosyphilis, Lyme disease, other non-specific vasculopathies like senile arteriosclerosis, also known as Binswanger disease. So these are in addition to the cardiovascular risk factors we talked about. So these are the non-modifiable risk factors. In terms of the other modifiable risk factors, we had talked about cardiovascular health, so making sure their hypertension is under control, making sure that in terms of atherosclerosis, that they're on the right medications, they're following a diet that helps at least lower their plaque burden and help with lowering their cholesterol levels. In terms of diabetes, making sure that's under control. If they have an irregular heart rate, like atrial fibrillation, then make sure that they're on the right medications to control that and to keep them physically active and to avoid any substance use if they can, since that can, of course, affect their cardiovascular health. And again, this is stressing that we really, with those who have vascular dementia, we really do focus on cardiovascular health to at least prevent them from having further worsening of the vascular dementia. So working on the hypertension, diabetes, hyperlipidemia, metabolic syndrome, any irregular heart rhythms, and then a history of atherosclerotic disease, so making sure those are under control. In terms of treatment for vascular dementia, like I had mentioned, there is the theory that patients who have vascular dementia can benefit from cholinesterase inhibitors. It's not formally FDA approved, but you can prescribe a cholinesterase inhibitor with someone with vascular dementia. Since there is the evidence that there's overlap in the pathophysiology between Alzheimer's dementia and vascular, which is the cholinergic deficit. Neurochemical studies suggest that cholinergic system is intact in purely vascular dementia, but affected in mixed dementia. So if you're pretty certain it's purely vascular and you don't have any suspicion of Alzheimer's dementia on top of it, then it's less likely to be beneficial. But if those who have maybe a mixed dementia with Alzheimer's and vascular type, you could consider prescribing them a acetylcholinesterase inhibitor. The mainstay of treatment for vascular dementia, blood pressure control, making sure that they're on the right medications such as statins or aspirin if they need to be on it, lifestyle modifications, making sure that their cardiovascular health is optimized with exercise and appropriate diet, managing any comorbidities and mitigating risk factors like substance use, and making sure that they have good support at home and that they're staying socially engaged with the community. So in terms of the cholinesterase inhibitors in vascular dementia, in a 2005 combined analysis of 2 identically randomized controlled trials, it was shown that donepezil at a dose of 5 milligrams and same as a dose of 10 milligrams has significant benefits in cognition and global function and ability to perform IADLs with good tolerability and low withdrawal rates. And this is when it wasn't done in a study for patients who had vascular dementia. So they did find benefits in using donepezil 5 milligrams or donepezil 10 milligrams. In a Cochrane Library meta-analysis review of 8 trials. So they looked at 3 trials that looked at donepezil 5 or 10 milligrams, 3 trials that looked at rivastigmine at a maximum daily dose of 3 to 12 milligrams, and 2 trials that studied galantamine at a maximum daily dose of 16 to 24 milligrams. There was moderate to high certainty evidence that donepezil 5 milligrams and 10 milligrams and galantamine had a slightly beneficial effect on cognition in people with vascular dementia. Although the change was not very clinically important, but there was benefit. Those who were on donepezil 10 milligrams and galantamine 16 to 24 milligrams had more adverse effects than placebo, and the evidence for rivastigmine was less certain. So in overall, the evidence isn't very strong, but they have seen some benefits with a lower dose of donepezil 5 and 10 milligrams for those who have vascular dementia. So in terms of prognosis in vascular dementia, when we diagnose them with purely vascular dementia, it all depends on, again, where the stroke happened. Was it a large vessel or a small vessel was affected? Is it multiple strokes that they've happened or multiple vascular insults that they've happened? It's very variable. So on average, a patient who's diagnosed with vascular dementia has a lower life expectancy because they have so many other comorbidities and they're more frail in general. So it's a lot more variable in terms of prognosis. But in general, we do see that those who have vascular dementia, because of their other comorbidities, tend to have less life expectancy than those who have purely Alzheimer's dementia. So it's hard to predict. So I usually don't give them any sort of prediction of when, in terms of life expectancy, it's hard to predict that, but I do tell them to take care of their cardiovascular health as best they can, make sure they follow up with their primary care doctor or their specialist, make sure they're optimized and keep their heart and brain health as well as they can. So with that, I think these are my resources for today. And thank you so much for listening. I wanted to give a few minutes if there were any questions